Recording started. Start here.
Yes, yes. Good afternoon, all. I'm Dr. Shyam. Welcome to the sixth webinar of IDA Erna. Let me introduce our speaker, Dr. Mandar Pimpirkar. Dr. Mandar graduated in 1993 from Bharati Vidyapeeth Dental College, Pune. Since then, he has maintained in specialty practice in endodontics and microendodontics. He completed his postgraduate in endodontics from New York University College of Dentistry in 2006. He is actively involved in continuing dental education and has conducted hands-on workshops across the country and abroad. Dr. Mandar has invented and designed Endo Irrigator Plus Pads Pro agitator tip system and also formulated Twin Clean, a single-step irrigation in endodontics. Now I invite Dr. Mandar to start the webinar section. Thank you.
Okay. So I'll start with the share screen, correct?
Yes, sir.
All right, friends. A very good afternoon to all of you. And as you can see, I am perfectly bearing a quarantine look. So it's been a month or so at home, and quite surprised to see a lot of people online to attend this webinar. And it's really a pleasure. And I did meet with Dr. Sabish and Dr. Tom in Mumbai in the month of February, and we had a great time. So it's okay if we cannot meet physically. The technology like Zoom and OBS we have managed to enter into your drawing rooms and the dinner table and the comfortable bed in your bedroom, from where we can continue the process of learning. So first of all, let me thank Dr. Sabish, President Dr. Balakrishnan, Secretary Dr. Sanal Babu, and CDE convener Dr. Shyam, who assisted me throughout how to go about the Zoom. So today, it will be about 2 hours of discussion. I'm going to present on a few aspects of irrigants, the irrigant activation, and the complications associated with irrigation, and how do you prevent them or how do you manage them. So I come from a city that is Nasik. It's about 150 kilometers from Mumbai. So whenever we start doing any endodontic procedure, the first thing is to have an absolute three-dimensional view of the root canal anatomy. Now, every root canal anatomy is going to be different, and there are going to be challenges in terms of removing the pulp tissue. There will be curvatures, there will be isthmuses, the interconnections, the apical deltas to deal with. We have to be centered in our preparing the canals so that the file always remains in center and do not weaken the tooth structure. Now with the advent of CBCT, you can slice the tooth millimeter by millimeter and see how the canals divide, merge, and not a single canal is round in shape. Neither a canal is straight. It is curved in some or the other plane, which you really don't know unless you take a third dimension. So we have to have a strategy to deal with this complex anatomy to remove the pulp tissue, because wherever there is pulp tissue, it can harbor bacteria. That primarily we all should remember. Now, when you go on Facebook, you will see all these kind of the comparisons of the root canal anatomy with different shapes like ballet dancers, some yoga poses, some owls to horses to cars to towers. I don't deny that these obturations are not good. They are beautifully done root canals with biomimetic shapes being preserved. But what we are forgetting in this process is we are forgetting the biological considerations. So now if you look at these radiographs here, what we want to do predictably is to get from this situation to this situation, get from this situation to a healed, completely healed situation, get from this chronically infected periapical lesion to a completely healthy bone. So we have to ask ourselves that, of course, I don't deny that shapes are not important. Shape will only facilitate the cleaning, and shape will only facilitate the packing of the root canal system. So we must understand and have biological considerations when we do any root canal procedures. That is the most important aspect. So I have divided this presentation into three aspects. One is cleaning the debris, second is clearing the smear layer, and third is conditioning the dentine. So you should remember 3 C's in endodontic disinfection. So let's start with understanding why irrigation is so important. Now, if you look at this complicated block, which I'm showing on the screen, the file starts to rotate in the root canal. If you notice, it is not contacting all the canal walls. Am I right? If you notice, it is generating a lot of tissue debris. Here you can see the apical vapor lock, where the solution is hardly present in apical 1/3. So what we need to understand is an endodontic file will only contact to only 30 to 35% of the root canal walls. Rest all job has to be done by your irrigants. Now, if you look at this file rotating in the canal, can you see a smear plug getting built up here? So with every rasping action of the file, you're going to build a smear layer or a smear plug which gets packed into the dentinal tubules and the lateral canals. So if you don't have an irrigation protocol in place, you will be packing the debris into the lateral canals and the dentinal tubules. And the further penetration of your antibacterial solutions will be prevented. And you may not have predictable results all the time. So only delivering irrigating solution is also not enough. You need to activate the irrigating solutions so that you get rid of this apical, the smear layer or accumulated hard tissue debris, so that there is a constant penetration of your irrigating or antibacterial solutions. So I hope you have understood why irrigation is so important. Then there are few set of challenges we have to overcome. One is the root canal always behaves like a closed tube model. Then there are going to be uninstrumented parts of the root canal system. Then you have isthmus shaping and isthmus cleaning, which is a fundamental important step. Then every dentinal tubule can act as a canal, and there are millions of them, remember. Then we have to have dissolution of organic matter from main body of the canal and also from the lateral canals. And we are up against with mono and multi-species biofilms. So these are a set of the challenges. And if you can see this premolar, how many portals of exit this has. I hope this is not covering, my PIP is not covering the slide. If it is not, then you will be able to see that there are multiple portals of exit in this premolar. So we have to have a strategy to clean all these multiple portals of exit. Now, if you look at this, when I talk about the uninstrumented parts of the root canal system, if you look at this, these are some of my research work where I clear the teeth and try to understand the internal anatomy of the root canal system. If you look at this mesiobuccal root, wherein there is a emergence of mesial third from the junction of middle third and apical 1/3 of the mesiobuccal canal. Now, essentially, this becomes an uninstrumented part for me. Now, if I do not have, or if I do not drive irrigants, after shaping the main body of the canal into these irregularities or the mesial thirds, which are inaccessible to any endodontic file, I'm going to leave behind a lot of tissue. And if I leave behind tissue, 5 years down the line, you are going to invite failures, so that we do not have a predictable outcome all the time. So one should visualize, one should be aware of the normal configuration and should be aware of the variations in the root canal system, so as to completely three-dimensionally clean and pack the root canal system. Now, if you look at this further clear teeth images, if you can count here how many portals of exit this premolar has. Look at this complexity, look at this bifurcations, look at this lateral canal, look at these multiple portals of exit. Look at these two portals of exit poles apart in a premolar root. And apical 1/3 essentially becomes a blind procedure for us. So if we really do not have a visualization of 3 dimension and do not have any irrigation protocol in place, I am sure, I don't think we can be predictable all the time. But yes, if you have that visualization, and if you can visualize few things and do it intentionally, if you are dealing with the lateral canals, it is possible to clean and fill the lateral canal. It is possible to tackle the apical splits. This is by way of driving your irrigants into one of the apical split by shaping the main body of the canal. Here you can see multiple portals of exit. Here you can see network of accessory canals. So these all variations do exist. Now you may ask, or there could be a question in your mind, that I've been doing root canal for so many years and I did not find any lateral canal, or I did not fill any apical delta, but there were no failures as well. Yes, I agree to it. But it could be a case that this apical split or a lateral canal may not be harboring an infected tissue. It could be a vital tissue there. So a clinically significant point, whenever you see a lateral lesion, apart from the periapical lesion, suspect that there is going to be a portal of exit. So if you have an evidence of lateral lesion on the root surface, that means you have to intentionally clean that lateral canal so as to make the lateral lesion heal completely. So straight away coming to cleaning the debris. So if you sometime have a look under magnification, after you have instrumented a canal, look at the debris, how much it has been generated by your endodontic file. And file after file, we keep on instrumenting and start accumulating and start packing the debris in on all aspects of the root canal walls, including the apical 1/3, which is typically called as apical plug. So a continuous irrigation after every instrumentation or after every instrument goes into the canal is critically important. Now, what I do in my clinical practice. Now, if you look at this image, can you see small tissue tags here? A pulp tissue in the crevices where your endodontic file is not going to touch. So essentially, these areas remain untouched by your endodontic file. So when you do your access preparation, make it a point to pour a few drops of sodium hypochlorite or twin clean. I will tell you about what twin clean is. So if you place few drops of hypochlorite into your prepared access cavity, the prerequisites for access cavity would be pre-endodontic build-up, so that your solution is contained into the prepared access cavity. Use of rubber dam is mandatory, and now with this COVID-19 coming up, it will be mandatory to use rubber dam to reduce the aerosol and cross infections. So coming back to what I do in my clinical practice is, when I'm completed with my access preparation, I pour a few drops of hypochlorite or Clean and wait for 1 minute. Now this 1 minute is passive wait. You have to wait 1 minute by watch. You can agitate that solution with DG16 probe, or you can use ultrasonic. You will see in a video in a short while. And evacuate that solution after 1 minute. Now, likewise, if you do this 2 cycles or 3 cycles, so that is 3 minutes, you will get a shiny pulpal floor because hypochlorite or twin clean will dissolve these tissue tags. And then you will have a shiny, bright, illuminated floor of the pulp chamber on which every dark spot could be your orifice. So it helps us in finding the orifices. Also, when you have a shiny floor like this, remember the floor of the pulp chamber is always gray in color. So anything brown on that gray background has to be a secondary or tertiary dentine, or we call it as calcification commonly. So you have to get rid of this. Now, if you can see here, this is mesiobuccal, and here it could be MB2. So if you have a lot of tissue here, a lot of debris here, you really can't see anything. If you are not using operating microscope, at least a clinician should start using the magnifying loops. Then only you will be able to appreciate these things. So that is why I say when it is dark enough, you can see stars. And when it is bright enough, you can see orifices. So you have to make the floor of the pulp chamber clean first. Remember, we are now with the concept of crown down. What do I mean by crown down? You're going to divide the tooth into 3 parts, the coronal 1/3, the middle 1/3, and the apical 1/3. So if you are able to take care of the pulp tissue, which is there in the pulp chamber and coronal aspect of the orifices, you have taken out 60 to 70% of the bacterial load or the tissue load on the tooth without touching the file. So don't be in a hurry to insert your file as soon as you open the access cavity, because access is destiny in endodontics. You have to spend more time on access and clean the access cavity first and then proceed further. So finally, the chamber should look like this, without any debris, without any tissue tags, and shiny pulpal floor. So sodium hypochlorite or twin clean being a bleaching action, it will completely bleach the floor. And then you have a clean chamber to work with, and then there are less chances that you will miss on any accessory canals or accessory orifices. Once you have done this, then is the time you have already found the orifices, and then is the time to perform or incorporate one step into your day-to-day practice is isthmus shaping and cleaning. Now, if you can notice here, this is complete isthmus. This is interconnection isthmus. This is isthmus in middle 1/3. And this is also an isthmus in extending till apical 1/3. So if you are not able to clean these areas, this is the area where the toxins will be deposited into the furcation area. And then we wonder why these furcation lesions do not heal. Because no matter you're cleaning the main body of the canal, but you are not able to clean these isthmus areas which holds a lot of tissue. So better idea to incorporate into your clinical practices. Now, this is what I do when I do my access preparation. So I'm pouring few drops of irrigants. It could be sodium hypochlorite, it could be twin clean, and wait for a minute. Now, as soon as you introduce hypochlorite or twin clean, you can see bubbling action. Can you see the bubbling action throughout the length here? Throughout the width rather. This indicates that I'm not dealing with a circular canal. It is a complete dumbbell shaped canal. And as I told you, that the floor of the pulp chamber will always be green. So if you shine a light cure light to the tooth, you will see a lot of bubbling. Now this is called a champagne test. Now if you see the bubbles are emerging throughout the width, that is line joining mesiobuccal and mesiolingual. That means there could be a possibility of mesial third. Once you have done this, can you appreciate the cleanliness of the chamber? Yes. Now again, don't be in a hurry to pick up your 10 number file, because there can be these small tiny calcifications which are sitting on the orifice. The moment you insert the file, you're going to push this deeper into the root canal system. So if you see a gray floor and yellowish or brownish deposit here. This is mesiolingual, this is mesiobuccal. What I'm going to do is I am going to shape these isthmus with an ultrasonic tip. What I'm going to do at a power setting of 3 with a water switched off, any diamond coated ultrasonic tip used for endodontics, say by Startex or buck tips, there are a lot of them available. You just have to join mesiobuccal and mesiolingual. This takes hardly 2 minutes. Now, I would prefer to do this when my irrigant is there in the chamber, but for demonstration purpose, I am cutting it dry. All right. So when I'm using a irrigant with this, I am also activating the irrigant. So that further enhances the action of hypochlorite or twin clean. Now I'm joining mesiobuccal and mesiolingual, and I've removed the calcification from that part. If I would have not done this, I would have just shaped mesiobuccal and mesiolingual. And then I am at a greater chance of missing the mesial third, which is always present between mesiobuccal and mesiolingual. After this is done, you pour irrigant again, and you can activate, or if you want to activate with the irrigant, here is how it is done. So you pour the irrigant and then activate the ultrasonics. So here the debris which is getting generated will be kept in a floating state, and it will not settle down and will not enter into your orifices. So a 1 minute of activation is extremely helpful to shape the isthmus, because no file will do this job for you. Now, once cycle is over, you evacuate the old solution. Now here you can appreciate, can you see the isthmus now? Because I have removed the calcification. This is mesiolingual, mesiobuccal, and then I am in a better position to find my mesial third if it is there. If it is there, it may join mesiolingual or it may join mesiobuccal. Very rarely it exits as a separate canal. So this is one step which everyone has to follow when treating molars and premolars. Because if you leave behind so much of tissue in the isthmus and you are not reducing the bacterial load on the tooth, that is important. So you need some form of magnification, you need ultrasonics, you need copious amount of irrigation, and you need right choice of irrigating solutions. So this is how we start with. And then this is the thin lip of the dentine, which is to be removed with ultrasonics. And then you can have a clean chamber like this. And this is a video where you can see what actually happens in the isthmus area. When the file rotates, it gets loaded with the debris. And if you do not use good amount of irrigants to clean that isthmus, it will be still loaded with the accumulated hard tissue debris. So always try and incorporate this isthmus shaping and isthmus cleaning. So this is a clinical video where you will be able to see that how actually it is done. Now this is a premolar. That's an ET18 tip by Satellax with a power setting of 3 on an ultrasonic. You just shape the isthmus. And to your surprise, the bifurcation can be till middle 1/3 when the canals bifurcate. So just don't focus on the main canal. We have to think about this isthmus, shaping them, cleaning them. And it hardly takes any time. You really don't require the expensive armamentarium for this. One tip, which will be costing around 3,500. And I have bought it and I don't remember when I bought it. So I've been using that years together if you use it correctly, if your method of use is correct. So this is the idea behind shaping the isthmus. So I hope everyone will start incorporating the isthmus shaping into their practice. So typically when we instrument the canal, the file starts rotating in a single rooted tooth. But in single rooted tooth, we are in a better position to auger the debris out. But in multi-rooted tooth, the file starts rotating and starts pushing debris into the isthmus, which is inaccessible area. So whether you rotate or you reciprocate, you have to use irrigants in between to keep the isthmus free of the accumulated hard tissue debris. There are a couple of studies which tells us that accumulated hard tissue debris is produced either by way of doing reciprocation or rotation. So we have to keep, this is very important aspect, and we generally overlook this and do not pay any attention to isthmus shaping. So everyone should start doing isthmus shaping. What does this study tells us? That only 30 to 35% of the time the file will be touching on the canal walls. So we have to rely on irrigants, more on irrigants to treat the root canal surface. Now this was another landmark study which showed us that the isthmuses are completely loaded with the tissue or the accumulated hard tissue debris. So the question is, can we do better? And answer should be yes, because if you want to be predictable all the time and allow the lesions to heal, you have to incorporate these steps. Now, if you look at this extracted tooth, this was one of my case, and which had to be extracted. You see this mesial third, you see this interconnection. The obturation on the radiograph was looking perfect, but the tooth was failing. There were symptoms. Patient was having pain. And when I extracted the tooth, I decided to clear it and see what actually went wrong. And here you can see a lot of debris which I pushed into these areas, and the percussion lesion never healed. So we have to have that three-dimensional approach and have a strategy to clean these areas. So coming to the topic, that is irrigants. What irrigants are available to us? We have antibacterial solutions. We have decalcifying or chelating agents. We have antibacterial and chelating agents in combination. We have detergents added to it, and we have some combination of solutions available to us. But till the time we find something else, sodium hypochlorite is going to remain as indispensable solution in endodontics, for the simple reason that only 6% hypochlorite was able to remove the biofilm and prevent its growth. So few people are still using chlorhexidine as an irrigant, but I will come to that. What is the controversy on chlorhexidine and what is the advice whether to use chlorhexidine or not. But hypochlorite remains the indispensable solution in modern endodontics. Now, when you use sodium hypochlorite, there are going to few factors will affect the use of hypochlorite. First is the volume of solution used. Now, Schilder used 39 ml of solution per visit. Now, if we are not Schilder, we can at least use 15 to 20 ml solution per tooth per visit. Now, here the question will be, what if I am doing a one visit root canal? Somebody may ask, what if I am doing two visit root canal? Sometimes the situation will demand multiple visits root canal. That depends on the status of the tooth or the infective status of the tooth. Now, in my practice, I generally don't do one visit endodontics. Now, why I am telling you this? Because I can increase my volume of solution used in 2 visits. And my second visit is only dedicated to use of irrigants and activation methods. So in first visit, I follow a protocol of shaping and cleaning using a good volume of hypochlorite or irrigating solution with activation, complete my preparation, select the master cone, and the next visit, I do not touch the endodontic files. Next visit is only dedicated to cleaning, cleaning, and cleaning. So next factor will be contact time with the tissue. The studies have shown that the hypochlorite takes about 40 to 45 minutes or maximum 50 minutes to take care of all the pulp tissue. Now, does it mean that you're going to irrigate for 50 minutes? No. I told you my irrigation starts at the access preparation. So I am trying to keep hypochlorite or my twin clean in contact with the root canal system throughout the procedure. Normally, I take about 50 minutes to completely finish a molar. So during that 50 minutes, I am ensuring the contact of hypochlorite or other irrigating solutions into the root canal system. That's how you satisfy the contact time with the tissue. Concentration of the irrigant, it is um, we have 3% and 5% available commercially. Now, if you are using 3%, then you may have to increase the volume a little bit. If you're using higher concentration like 5%, you may settle down slightly for a lesser volume. But there is nothing prescribed anywhere and this much should be used. But 15 ml plus should be used. More, the better. Then the temperature of the irrigant. Now, if you increase the temperature of hypochlorite, you will be amazed with the results. I'm going to cover few of the aspects that how do you warm the hypochlorite. So I will leave it to the later part. Then refreshment of the hypochlorite, we all should remember, as I told you, 3 cycles, 1 minute each. Because after 1 minute, the hypochlorite starts to degrade when in contact with the organic matter. So unless you refresh, evacuate the old solution and introduce fresh, the free chlorine of the release of chlorine, once the chlorine is released, the hypochlorite becomes normal saline. So you have to constantly refresh the tooth with by introducing the fresh hypochlorite solution. And then agitation and activation, which will be covered in detail in later part. So in short, factors which governs the irrigation with hypochlorite or twinkling is bigger the volume, longer the time, contact time, higher the concentration, higher the temperature, better, deeper will be the penetration. Because there is an evidence that these microorganisms can sit into the dentinal tubules about 300 micrometers. So we have to ensure the penetration of your irrigants to that level and disinfect the dentinal tubules completely when it comes to chronically infected teeth. So we have to be with a concept that is instrument shape and irrigants clean. So red zone is where your files are going to touch. Green zone where your files are never going to touch. So you should have an effective irrigant which will reach the apex, which will create the current and remove the debris out. So keep one thing in mind, instrument does only 30% of the job. 70% of the job is done by your irrigant. And there are further factors involved in fluid dynamics. If you understand the fluid dynamics when you do irrigation, one is the apical vapor lock effect, then is the stagnation plane, and what is the depth of your irrigation. These are 3 important aspects one should address. Now, apical vapor lock is quite evident. It was thought that it does not exist, but 2003 study by Torabjinat indicates that yes, the apical vapor lock does exist. Now, what is it? When you start introducing hypochlorite, it hydrolyzes the tissue. Once the hydrolysis of the pulp tissue is on, there are some formation of gases, and these gases, they get settled at the apical 1/3. Now, law of physics, where there is air, the solution cannot enter unless you are able to break that apical vapor lock. So we will see what are the methods of breaking this apical vapor lock effect. And if you remember the first video which I showed you, in apical 1/3 there was no solution. The file was rotating in air. So we have to make sure that the hypochlorite reaches to that critical apical 1/3. Now, there was this another theory or study by Dr. Gulabiwala. This is dead water space or stagnation plane. Now, imagine this scenario and your needle is inserted. You're treating the upper tooth, the maxillary tooth. These are 2 side ports for the needle, and you start pushing the solution. The solution will hardly reach to the tip of the needle. So, side vented needles when used, and when you extrude the solution is inactive 1 millimeter beyond the point of the tip of the needle. So the solution is going to start trickling down and it will be evacuated. That's typical positive pressure irrigation. So unless and until you are able to place the needle into last 1 millimeter of your working length, then only you are making solution available to that apical 1/3. That brings us to an important aspect, and that is the study which says that minimum preparation should be 30 ISO. Taper, you can play with the taper either 4, 5, 6. Greater than 6 are not now preferred because we came across with a lot of vertical root fractures. So we are again back to moderate tapers. 6 is a magic taper, but the apical enlargement should be at least 30. Why? Because we need to know the depth of the irrigation. Also, when you take preoperative radiographs, you assess the width of the root. This will allow you to decide what taper you are going to finish at. If you are dealing with thin and slender roots with less amount of dentin remaining, then you have to settle down for 4 taper and have your activation, irrigant activation strategy in place. But if you are able to enlarge it to 6 taper, nothing like it. Because 6 is a magical taper where the studies have proven that if you are able to shape the root canal system to a 6 taper, the canals were found to be cleanest. So wherever possible, go to 6. And if you're not able to go to 6, even in 4 taper, you will have to have a stringent irrigant activation regime in place to effectively clean the root canal system. So this brings us to tip versus taper. Now, if you look at here, 3004, after every millimeter, it becomes 34, 38, 42, 46. If you consider a situation like 2506, now which is more destructive? So there are two schools of thought. One says that increase the apical diameter and keep the increase the taper. The second school of thought says you keep the apical foramen as small as possible as 25 and increase the taper. So if you look at the fluid dynamics, then keeping the apical foramen as small as practical and playing with the taper depending on each and every root's thickness will allow you to clean the root canal system in 3 dimensions. Because there are going to be more variations in apical 1/3, so I would not recommend you to increase the apical diameters to 35 and 40. Better keep it at as small as practical and play with the taper, because taper will decide the volume of irrigation. And also we need to know that what kind of irrigating needles we are going to use, because the study told us to increase the apical diameter to 30. That is simply because you should be able to deliver the irrigating solution in last 1 millimeter of the root canal, your working length. You should be able to place 30 gauge needle which corresponds to 30 size ISO instrument. Now, if you are using 27 gauge, 26 gauge, 25 gauge, the corresponding diameters could be the 40 ISO, the 45 ISO, and 50 ISO. Now, in which situations we are increasing it to apical diameters of 40, 45, and 50? I don't think so. So, the shaping has to be cleaning driven. You should be able to deposit the solution in last 1 millimeter of your working length, and that is possible only with 30 gauge needle. Keep it in mind. There are different types of needles also available. Try and use side vented needles. Don't use this side cut needles, because if you're dealing with curved canals, this is a weakest point. It may just break here. Don't use the beveled needles. Always resort to using the side vented needles. And it's a palm grip which is preferred. Don't use the thumb grip, because you tend to apply a lot of pressure, and that can cause hypochlorite accidents in your practices. So what are the take home messages when it comes to irrigation? you should be using side vented needles during irrigation. The needle should never be locked. You will see in a video that how do you actually do manual irrigation. Then root canal needs to be enlarged to about size 30, combining with different taper which the tooth allows you to do. And you cannot exceed a flow rate of 0.25 ml per second. So ideally your flow rate should be 15 ml per minute to augment both the chemical and the mechanical actions of the irrigation. So this is now one thing which is next in pipeline from me, where I have designed a tapered needle which is 30 gauge and which has two side holes. Because one side hole, you have to keep on rotating the needle to get irrigant in contact with all canal walls. So this is going to be the next launch, that is polypropylene autoclavable tapered needles, which has a 30 gauge size. Anyways, let's come to the objective of irrigation. Our objective is that irrigant should reach to full extent of the root canal system. You should ensure adequate delivery because irrigation is a game of volume. You should allow refreshment of irrigants. Then it should ensure some shear stress on the canal walls as the solution moves up and down. And it should be confined to the root canal system, and it also should provide lubrication. Now, there are different methods with which you can do this. Now, if you can look at this, this is the tapered preparation, and this is how you want your irrigants to move into the prepared root canal. So there are different ways with which you can do the activation. One is the manual dynamic agitation. Then is the passive ultrasonic irrigation. Then is the sonic activation. Then is the air sonics. Then is the negative pressure irrigation. And the last is intracanal heating. So these are the methods with which you can activate your irrigants. Now this is how typically we do irrigation in our day-to-day practice with syringe and needle. You see, you should not be locking the needle into the canal. You should be always moving the needle up and down. If you lock the needle, then the flow rates under pressure will cause the hypochlorite accident. And try and keep the use the surgical suction, which actually fits into the chamber. So, and isolation with rubber dam is mandatory. So that is the manual method of irrigation. Then how do you get rid of the apical vapor lock? This is manual dynamic agitation. I'm sure many of you must be doing this. This is the most inexpensive way of doing any activation. So once the root canal is completely prepared, you select a master cone which is customly fitting into the preparation, and you pour irrigants into the prepared canal, and this is how you do it. And once you pour the irrigant, it can be hypochlorite, it can be a final rinse with EDTA, it can be a final one-step solution like Winclean. Now I have poured irrigant into the prepared canal. I know my working length, and I'm going to be short by 2 millimeters of my working length and use a self-locking tweezers and insert that selected master cone into the prepared canal, which is filled with the irrigant. And you should be doing short strokes, vertical strokes of short amplitude. Now, the idea behind this is when the GP is, you are activating the GP, you can see the solution moving in the isthmus area. Now, this is pushing of irrigant into the irregular spaces. And with this, you will be able to get rid of that apical vapor lock to some extent. Because when the GP moves up and down into the canal, it carries some solution with it. And that is how you can make the solution available in apical 1/3. Next, commonly employed method is sonic. And many of you must be using also some or the other sonic device. Now it has one node and one antinode and has about amplitude of 1 millimeter. So when this tip is allowed to vibrate into a confined canal, which is amplitude based, we should understand between amplitude and frequency. Amplitude is you can visually see the movement. Frequency you cannot. Frequency is acoustic streaming. So commonly used is the endoactivator, the sonics. Next method is the ultrasonic, which is frequency based and not amplitude. So there are multiple nodes and anti-nodes along the length of the tip. The commonest example is Irrigation by satellite, where the metallic file attached to ultrasonic is made to vibrate. Now both sonics and ultrasonics, they are used for activation of your irrigant once the root canal has been prepared to master a apical file. So you're going to use them only after you have finished your preparation and activate the irrigant. Now here is one video which has a commentary, so you can just listen to it. And here I've tried
activation
to
or agitation of
compare.
the irrigants can be done with sonics, ultrasonics, and air sonics, apart from manual dynamic agitation. Currently, you're looking at the form of sonic activation, which is an amplitude-based system. The tips are made of polymer, which are flexible. As you can see, this sonic activator at its maximum frequency produces a very weak cavitation effect and hardly generates any shear stress on the canal walls to remove the debris out. The next form is the ultrasonic activation. Typically, a metal tip which is mounted on ultrasonic scaler is allowed to vibrate in the prepared root canal system, which is filled with the irrigant. Although this produces good cavitations, the metal tip is difficult to be worked around curved canals while it is vibrating. It may alter the normal canal anatomy. And most importantly, if you can notice in this video, the moment the tip contacts the canal walls, the cavitations are lost. So although very effective way of activation, ultrasonic comes with a lot of limitations. And this is air sonic pro-agitator tip system or PADS. This is frequency based, being a sonic system. So basically it has a safety of sonics since the tips are made of polymer, and has an efficiency of ultrasonics because it primarily works on the frequency and not the amplitude. As you can see in the video, it actually creates a turbulent effect, creates the cavitation effect. You can see the isthmus cleaning very efficiently done. We all understand that activation of the irrigants is a must step, and we should wisely choose our device to activate the irrigants, not just because something is coming at a very low cost.
Okay, so now if you saw in that video, I wanted to highlight few things. Sonic, you should always remember, sonic is an amplitude-based system, and ultrasonic is frequency-based system. Now, using any sonics, the advantages, the tips are made of polymer, so there are less or no chances of breakage of the tip, but it produces a very less cavitations. But if you resort to using ultrasonic, which is frequency based, but the advantage being more efficient, but the disadvantage being the tips made of metal, you cannot really work around a curved canal, or it can gouge the canal, or it can alter the anatomy of the canal. So now we have sonics and we have ultrasonics. Now, what I thought was we should have something in between which will serve our purpose and will have efficiency of ultrasonic and safety of sonic. And then I designed this patch which works on air. So it's an air sonic. So being a sonic, this is not amplitude based, this is frequency based. So you will not see the tip moving, but it will create cavitations with the help of frequency. And it is very user friendly. It comes with a special handpiece which fits onto your air rotor coupling and it runs on air. We have designed in such a way that it creates a frequency to the tip and it's a bodily movement. So maybe in this video, you will be able to see that how it actually pulls the debris towards it and it breaks down the debris completely. Here you will be able to see it's a bodily movement. Now it is pulling the debris towards the center of the canal. It also creates the vortex around the tip where you can see the debris is constantly pulled out. So with the help of the polymer tip, which is frequency based, it is extremely safe and more efficient because it has a bodily movement. So being sonics, it is more efficient, it creates more cavitations, and it generates a lot of acoustic streaming, which helps in cleaning or cause a shear stress on the canal walls. So either of these three, you should be incorporating into your clinic for the root canal irrigant activation. So the next method is the negative pressure irrigation. Now, I don't know how many of you are aware of this term because there was one device earlier available called Endovac, which was manual. And somewhere in 2013, I designed the Endo Irrigator Plus. Forget about the device, but I will straight away come to the concept. Now, the syringe and needle irrigation, what we do in our day-to-day practice is we place the needle into the prepared canal and you start extruding the solution. Solution comes down from here and it is evacuated at the chamber level. That's called as positive pressure because the pressure in the syringe is greater than the atmospheric pressure. Now, the disadvantage here is when the solution trickles out from here, instead of trickling it down, it is immediately evacuated. So you are not sure whether you are making that solution available to this apical 1/3 or not. So when you do opposite of this, like you place a cannula into the prepared canal, which is in turn attached to a suction, and you pour the irrigant into the chamber. So what happens? Since this is attached to a vacuum, there is a vacuum created and solution is first pulled down here and then evacuated through this. So you are not pushing the solution, you're pulling the solution. So wherever possible. Now, the problem with negative pressure irrigation is you need a size of the root canal to be prepared at least 30, either 3006 or 2506. Now, clinically, if you go to see, you can use negative pressure in central incisors, in canines, in lower premolars, in distal root of the molars and palatal root of the upper molars, right? So these canals are basically wide canals to start with. So the criteria for negative pressure is that cannula should be reaching to the working length. Now, till the point the cannula reaches, the solution will be circulated. And when the solution is moving from here to this point, it causes a shear stress. And that is why negative pressure irrigation was thought to be the best way of irrigation and the safest way of irrigation because there are no chances of extrusion whatsoever. So wherever it is possible for you to use negative pressure. Now, the Endo Irrigator Plus is under redevelopment and it will be relaunched in a couple of months. And if you don't want to buy that device, it's okay. you can still generate your negative pressure irrigation manually by having a micro tips attached to a suction, placed it into the prepared canal, and ask your chair side assistant to drop the irrigant into the chamber, and it will be a continuous negative pressure irrigation. If the hypochlorite is warm, nothing like it. So wherever possible, try and use this negative pressure method. Now, just to show you one case here, this was a case with two instruments separated here. One was in the palatal and one was in the distal buccal. So distal buccal, it was easy for me to remove, but palatal was in the apical 1/3. So I decided to bypass. There was a draining sinus where the GP tracking test was done, and it was clearly indicating that the source of the focus of infection is related to the palatal root. Now, many times the instrument is not a problem per se. The instrument is lying there. It is still there in post-operative radiograph. But what was more important? It was the canal was not completely clean. There is a lateral canal here. So what I did was, I think this is a video where you can see, this is the Endo-Irrigator Plus. Now, this is simultaneous irrigation and evacuation because the suction is inbuilt. So you really don't have to apply a different suction. So one tip delivers the solution, the other tip sucks the solution. And also the solution is about 50 degrees warm. So all the factors of irrigation taking into consideration, increasing the temperature, refreshment because it is automated, negative pressure, safest and most efficient. So whenever it is possible for you, always resort to using negative pressure and use warm hypochlorite, and you will see tremendous improvement in your success rate. Here you can see the clean isthmus. Now I'm going to place into the other canal, and this is foot operated device, Endo-Irrigator Plus, and you can see constant supply of fresh hypochlorite happening, and this causes a lot of shear stress. So of course, if you do not have that device, you can always create your own negative pressure. Now this is the case where you can see the separated instrument, that's a shiny portion, and this I am using pads first to disinfect the remaining canal, and you can see the activation of irrigant. When you're using pads, you should at least use 1 minute per canal after your preparation is completely done. It is compatible to all the solutions. You can activate any solution, even a normal saline, before an obturation. So here I could bypass the palatal instrument, which was separated in the palatal canal, and then you saw the post-operative radiograph. So what are the points to remember? Taper decides the volume of irrigant. Syringe and needle irrigation, if you're doing, use 30 gauge side vented needle. Activation by sonics, ultrasonics, or air sonics, as I showed you in the video, is advisable. Choice is yours. Then refreshment of the solution is critically important because we know now the importance of refreshment because hypochlorite degrades very fast. Then negative pressure, which removes the vapor lock, and it is extremely safe. So you have to design your own strategy to deal with or to have an irrigation protocol. So combining few things like 30 gauge needle, either incorporating sonic, ultrasonic, or air sonics, and negative pressure wherever the anatomy of the canal allows you to do it, you should be doing it. So spend more time on irrigation and you will be delighted with your predictability and treatment outcomes in your day-to-day practice. I'm going to show you some of the cases. If you ask me to tame this Leo, maybe nobody of us will be able to tame this Leo, but we should be in a position to tame the Leos, that is lesion of endodontic origin. So if you look at these huge lesions here, now a surgical intervention here, very close proximity to the maxillary sinus would have been a challenge. So treating this non-surgically, following the irrigation protocol, which I told you, will allow you to to have predictable results over about 10 to 12 years follow. Another case with huge periapical lesion, actually a floating tooth, and we tracked this tooth month by month and saw that the lesion is completely healed within apical delta, where the sealer is still present and the healing is evident. Huge lesions like this, if you have a right approach, right irrigant strategy in place, you can make them heal. So this is about 18 months follow-up where you can see a completely healed lesion. A furcation lesion where the isthmus shaping and cleaning comes fundamentally important, where you can see the bone completely regenerating to a healthy state. Few of these again cases, these are just cases I'm going to run through because we don't want to waste time in that. But here you can see apical delta. Yes, you should be in position to clean this apical delta. Remember one thing, if you are able to clean them, you will be able to fill them by creating hydraulics. These are not apical pops. These are irregularities which are completely cleaned and then filled with the obturating material. So the irregularities and lateral canals should be free of apical debris, should be free of the smear layer so that your sealer can penetrate or obturating material can penetrate. These are trifurcations in palatal root. Again, a trifurcation in palatal root. Whenever you see a bulbous root or a periradicular lesion, expect that there will be more than one portal of exit. So in that case, you have to intentionally do the cleaning by choosing the right way of activation and the irrigant. The lateral canals, the loops and the recurrent canals, these are all there and you have to fill them. These are bifurcations, these are uninstrumented parts. Only irrigants can do this job and seal those portals of exit. Here you can see complete isthmus between mesiobuccal and mesiolingual. Then coming to a portion where we need to understand how do we tackle the smear layer. Now here I'm going to talk about new strategies that how do you tackle the smear layer. Now what is smear layer? It is comprised of organic and inorganic material which offers protection to biofilms. Then it interferes with adaptation of sealers and promote micro leakage. It promotes colonization of P. nigricans, which increases the chances of reinfection once the treatment has been complete. So removing smear layer is extremely important. Now smear layer, the tooth doesn't come with smear layer to us. It is you and me who generate the smear layer by introducing our endodontic files, whether in reciprocation or in rotation. So some of the studies which the micro CT images tells us that we tend to push a lot of smear layer or accumulated hard tissue debris into those areas. So now, as we were talking about irrigants, there are different combinations available commercially. You have smear clear, that is EDTA plus detergent. You have Chlor Extra, you have Chlorhexidine plus, you have Tetra Clean, you have MTAD, you have Q-Mix. But before we use any irrigant, we should understand the properties of irrigant. Now we are using primarily in practice is sodium hypochlorite, EDTA, and chlorhexidine, correct? But we should understand that all these reagents, they interact negatively. So if you mix hypochlorite with EDTA, it's going to react negatively. It will, the EDTA will render hypochlorite by allowing all the free chlorine to be released. Chlorhexidine and hypochlorite is a big no-no because it forms a parachlorine compound. And if you use mix hypochlorite with the citric acid, it also forms salts. So the new strategy is called as continuous chelation strategy. Now this is single step irrigation in endodontics that is called as squint clean. Now this was launched about a year back, which I formulated. Now, there is only one chelating agent, which is mild chelating agent known as etidronic acid or HEDP or HEBP, which is etidronate, which is a mild chelating agent. And this is the only chelating agent which is compatible with hypochlorite. It does not react with hypochlorite negatively. So what I thought was, why not to have a one-step irrigation solution instead of having multiple solutions to use and which they react negatively with each other. Why not to have one solution which will serve all the purpose of a ideal irrigant? So Twinclean is a combination of etidronic acid 9%, which is to be mixed with sodium hypochlorite. So again, we are not getting away by not using hypochlorite. So Twinclean is a powder form and it has to be mixed with hypochlorite freshly whenever you use. Now the dilution ratio is 1:9. If you have seen in the video, if you want to make a 10 ml of solution, you have to take 10 ml of hypochlorite and break 2 capsules on, mix the powder with hypochlorite. That becomes your single step irrigation solution, right from access preparation through the instrumentation. And as a final rinse, you can also activate this solution by way of sonics, by way of ultrasonics, by way of air sonics, also by way of negative pressure. So now you will be surprised why this is called as one-step irrigation solution. Now, if you remember, when we used to do composite restorations about 15 years back, we had etchant, we had primer, we had conditioner, and then bonding agent, right? Now everything we get in one bottle. So when I show you the irrigation protocol, you will understand why this is convenient. Now, what you may ask, what are the advantages of continuous chillation, if at all I want to shift from traditional irrigation to continuous chillation irrigation? Now, the studies have shown that there is a short-term compatibility of hypochlorite with etidronic acid. So when you mix the solution, it has to be consumed in 120 minutes, that is 2 hours. So that is why it is advised to mix it fresh before using it. So the stability or compatibility of hypochlorite with HEDP is about 120 minutes. Now, what could be the advantages? Now, continuous chillation is a concept. It is not only a solution. What do I mean by concept? Now, in traditional irrigation, we use hypochlorite, we use normal saline, and then we use liquid EDTA. Am I right? So this is normal saline to negate the effect of hypochlorite, then you use liquid EDTA. So you're using this in alternate fashion. So hypochlorite takes care of organic matter, liquid EDTA takes care of inorganic matter or smear layer. So in traditional irrigation protocol, we let the smear layer build first and then try to remove it with liquid EDTA. Being blind procedure, we are not sure that whole of the smear layer has been completely removed or not. In continuous chillation, what happens? Since you are using 2 reagents in one, the etidronic acid, which is a mild chelating agent, does not allow smear layer to form at all. And if the smear layer is not formed at all, the lateral canals, the dentinal tubules, they are kept patent or open to receive the hypochlorite. And that is why you have better penetration of hypochlorite. I hope you got the concept. So there is definitely a reduction of accumulated hard tissue debris during rotary instrumentation. The continuous chillation irrigation protocol optimizes the bond strength of the sealer, and it has been proven by a study. When you use epoxy resin sealers, the bond strength of the sealer, the dentin, was found to be maximum when you use continuous chillation concept. And the etidronic acid does not affect the chlorine release of the hypochlorite. Now, another important aspect of this combination is its pH. These are a couple of studies. If somebody wants to read further on this, there are a lot of studies. There are only two products in this world on continuous chillation. One is dual rinse by Zender Matthias in Switzerland, and second is by me, Twin Clean. So the biggest advantage of this combination is it lies in its pH. When you mix Twin Clean or you make a fresh solution, the pH is about 11.86. Now, if you look at E. faecalis, now here I'll talk talk about chlorhexidine. Why do we use chlorhexidine? We use chlorhexidine because it has a better action against E. faecalis, correct? But chlorhexidine is to be used in a substantive manner. It has to remain in dentinal walls for at least 2 weeks. So it cannot be used as a primary irrigant. It does not have any effect on the biofilms or penetration of biofilms. So advantage over chlorhexidine for the continuous chillation could be that E. faecalis cannot survive beyond a pH of 11.5. And when you freshly mix this solution, the pH is about 11.86. So 10 minutes of contact of this continuous chillation Twin Clean solution into the root canal system will take care of E. faecalis. So in revised treatments, in retreatments, or dealing with chronically apical lesions, it is advisable that you go with continuous chillation to have better penetration of hypochlorite. So that's a concept. It's not only a solution. And also some influence on smear layer because of etidronic acid not allowing any smear layer to form. So it's a simultaneous action. Etidronic acid not allowing smear layer to form, hypochlorite having better penetration. So that is why when you are using two reagents together, and that is why it is called as one-step irrigation solution. Now there were some studies done by postgraduates in our country, and earlier the continuous chillation solution was Chloroquick. Now it is Twin Clean. So they found that there is less or no post-operative pain because you're not allowing any accumulated hard tissue debris to generate, and you're constantly dissolving it, you're constantly augering it out. So there is no bacterial load or accumulated hard tissue load on the tooth. Another study which got published, this was by Dr. Pranav Thakkar, also compares with EDTA, and there was better smear layer removal. Now, if you compare this etidronic acid with EDTA, EDTA is a strong chelating agent. Citric acid is a strong chelating agent. Etidronic acid is a mild chelating agent. If you leave EDTA into the tooth for more than 2 minutes, it is going to erode the dentine. Citric acid, it is going to erode the dentine. But etidronic acid, even if it is left in the canal during the preparation, being mild chelating agent, it will not affect the dentinal structure and will not change the modulus of elasticity of the dentine. And that is critically important in terms when we face the vertical root fractures or weakening the tooth. So it is up to you what to do, whether you want to continue with the continuous chillation or be with the traditional irrigation protocol. So that brings me to a slide where I'm going to explain what should be the irrigation sequence during and after instrumentation. After a lot of things have been discussed about the activation, the irrigants, the advantages, the disadvantages. So the EDTA gel to be used during hand instrumentation to establish the glide path. Then you use normal saline. Then irrigate with 3% or 5%, preferably warm hypochlorite. During rotary instrumentation, use hypochlorite as your lubricating agent. Please do not use EDTA gel with rotary instruments. There are two things or two reasons behind it. One, we use EDTA gel to establish the glide path to chelate the dentin. Once the glide path is established, why do you need a gel again to drive your rotary instrumentation when the glide path is already there? And we use rotary instrumentation only if there is a glide path. So there is no point in using EDTA gel with the rotary instrumentation. Second point, that if you use EDTA gel with rotary instrumentation, as a rotary file generates a lot of accumulated hard tissue debris, the gel will allow the accumulated hard tissue debris to form into a plug. And gels are very difficult to refresh. So use liquid. Hypochlorite is the best lubricant. Then you will be using normal saline, and then use liquid EDTA to remove the smear layer which has been developed by your rasping action of the file. Once your master apical file is completely done, you have to use separately as a warm hypochlorite with activation the methods which I showed you earlier, either by sonic, ultrasonic, air sonic, or negative pressure. That is 1 to 3 minutes per canal. Then you're going to use normal saline again to wash out the effect of the hypochlorite. And then again, you will introduce liquid EDTA, which is 17% for 1 minute with activation, again with sonics, ultrasonics, air sonics, whichever way you want to do it. And then final flush with normal saline, that too with activation. So this is a conventional irrigation protocol which we are following, and if we are not following, then you should start following to have a set protocol. Because many times wherever I go to do a presentation, I ask participants that what's your shaping protocol. So everyone is ready with their shaping protocol, 10 number, 15 number, 20, then S1, then S2, or whatever file system they're using. But whenever I ask them, what is your irrigation protocol? There's a big silence. Nobody can tell me that what irrigation protocol they follow. Now, if you want to follow strictly irrigation protocol, stick a printout to your chair side and follow this irrigation protocol. Now, this is conventional irrigation protocol. If you don't want to remember all this, that what goes in first and what goes in later, and what are the interactions between the reagents, you can switch to clean clean. Here, you have to use only one solution. There is no need of using alternating solution, because hypochlorite and HEDP will take care of all the factors what you need for your irrigation. Now, these are some of the studies which are listed here. That's a continuous chelation irrigation improves the adhesion of epoxy resin based root canal sealers to dentin, and anti-biofilm activity. So now you have to decide whether you want to stick to the conventional irrigation protocol or switch to the continuous chelation. I don't know how many of you attended Dr. Prasanna's question answer session the other day. Now, I was very fortunate to visit Hong Kong University to do a presentation there in 2018. And Prasanna did a lot of study on continuous chelation, and it's preferred way of doing the irrigation now. And it is also compatible with all type of sealers, whatever sealer you use in your practice, whether they are tricalcium silicates or whether they are epoxy resin based or whether they are MTA based. So continuous chelation is compatible to all the sealers which we can use. So choice is yours, whether you want to have these many syringes on your tray or you just want to have one solution for all the problems, and which will take care of the smear layer, which will have better penetration, which will have better tissue dissolution and better antibacterial action. So that's about the newer strategy, that is continuous chelation. Then many of us asked me that is it really necessary to fill those lateral canals? Now, if you don't fill those lateral canals, now unfilled lateral canals, there could be pain during and after treatment. Then there could be recurrence of periapical disease. So as I told you in the start of the presentation, that if you see a lateral lesion, you have to suspect that there is some canal, some lateral canal draining the toxins into the periradicular tissues. So in that case, all these strategies play important role, that what strategy you are employing to clean the root canal system in 3 dimensions. So one of such case which I would like to show you, that there was a separated instrument in mesial system of the lower mole. There was a growing lesion. There was a furcation lesion too. Now, I did not remove the instrument because nowadays I prefer to bypass the instrument, because no matter, you can remove the instrument and be very happy about it, but then you have sacrificed so much of amount of dentine, and the prognosis of the tooth is a big question mark. So instead of removing the instrument, try and bypass the instrument. Let the instrument be there. Employ all the methods of irrigation and disinfection. And here you will be surprised to see that there was a mesial third which was completely missed. And there was a lateral canal bifurcation. And then it has to heal. If you treat the culprit, if you treat the problem, instrument is just one of the problem. But if you look at this, the lesion is completely healed. So instruments can lie there, you can bypass, provided you have a proper irrigation protocol. And also you can see 2016, 2019, 3 years follow-up. The sealer in the lateral canal in the furcation is resolved, but there is a healthy bone, there is healthy tissue at the periapex. So this is what the predictable endodontics is all about. Also, one of the case where you can see a separated instrument in apical 1/3 and a periradicular lesion. And you can see here that the problem was not the separated instrument, it was the missed lateral canal. And once you treated that, once you cleaned that, the lesion has to heal. Now, this was one case where I don't know if you can make out a mistake here. There is a big mistake here by me. And I managed to separate an instrument in apical 1/3, which was partly into the periapex. Now, this is end of the road, because it is very difficult to remove this instrument in this direction. You can remove the instrument from the tooth very easily from this end, but then it will be lying in the periradicular tissues. So what I did, I said, let's take a chance and clean it thoroughly. And I did follow a continuous chelation, all forms of activation, and spend almost about 40 minutes only on irrigation. And you can see the instrument is still there, but in that bargain, I could clean so many apical ramifications, and I could push my obturating material into those ramifications. Now, if I did not show you this, you could have easily said, oh wow, what lateral canals. But this is just a message to tell you, no matter if you separate an instrument in apical 1/3, it's not the end of the road for you. You can still try, disinfect the root canal space completely and obturate it. Keep the tooth under observation. Make the patient informed about it. Don't hide anything from the patient. That is the message. Here also, whenever you see the periradicular radiolucency, you expect multiple portals of exit, and they are there. So if you want to have predictable outcomes, you need to clean these root canal spaces, and with informed knowledge of the irrigants and irrigant activations. Here you can see trifurcation, again a periradicular lesion. So preoperative radiograph is telling you so much. Here this canal suddenly disappears. That indicates that there could be bifurcation, there could be trifurcation. So track the lesion, clean it. Irrigation is a religion now. You follow it religiously, and you will be delighted with the outcomes. We always talk about the working length. This is the working width. See how wide the canal is. Now, if there are challenges to negotiate the narrow canals, it's a bigger challenge to debride the wide canal. If you ask me what is the difficult most route to treat endodontically, my answer would be mandibular distal route, because the canal seldomly is round in shape, and it has different kinds of shape where you really cannot touch upon all the canal walls, and it is your irrigant delivery strategy and irrigant activation strategy will only take you through these kind of cases. So for to have these kind of three-dimensional cleaning and three-dimensional obturations, you need a continuous tapering preparation that is prerequisite. Then you should have absence of accumulated hard tissue debris. Now, I was stressing so much throughout the presentation about absence of accumulated hard tissue debris. Now, you have to decide your strategy, that which way you want to go. If you're not doing any activation in your day-to-day practice, please try and incorporate one of the methods which suits uh, economically and also ease of use. Then cone fit is extremely important, but obturation is not today's topic, so I will not talk much about it. And right choice of sealers, and you should be able to create hydraulics. If you have cleaned those irregularities, lateral canals, then if you do not create hydraulics while doing obturations, they will not get filled. So warm vertical compaction is one of the methods where you can create hydraulics. You downpack the master cone into last 4 to 5 millimeters of the working length, and that way you can create hydraulics where the lateral anatomies get filled automatically. So this was some overview of the irrigants. Now let's just quickly see what we discussed all this time about I don't know how much. It's 1.5 hours. Okay. So we discussed about strategies to deal with the isthmus shaping and isthmus cleaning. So it is advisable to incorporate that step. Start using ultrasonics for that. Shape the isthmus, clean the isthmus. Then we discussed about the different irrigating solutions. So hypochlorite being indispensable. EDTA is a strong chelating agent. WinClean is a mild chelating agent, and it's a single step irrigation solution. Plus, we also discussed about the activation of irrigants, sonics, ultrasonics, negative pressure, manual dynamic agitation. And then we discussed about a newer strategy called as continuous chelation. So this completes the irrigants and the irrigant activation part. Now, there could be sometimes when you encounter complications of endodontic irrigation. Now, when do we, this is quite a common scenario in the clinics, not to an extent where we have life-threatening situations. Now, if you go to see in the literature, or if you have a visualization, in my first slide, if you remember, I said root canal behaves as a closed tube model. That means there is some resistance by the bone and the periradicular tissues, which will not allow extrusion of your irrigants into the periradicular tissue very easily. No matter it happens by everyone, we tend to push few drops of irrigating solutions into the periradicular tissues. But the problems or the complications happen, or the symptoms do arise only when it is in excess. Few drops will not cause any problem because you're not exceeding sinusoidal pressure into the medullary bone. That's the baseline. So here there are few factors which will govern the complications. Before that, I would like to divide this complication into 3 different categories. One is a very common accident, since we do not use rubber dam, the hypochlorite or twinkline or any caustic solution tends to drop into the patient's oral cavity. This is a very common scenario. So in that case, patient may experience some burning sensation. Patient may develop some ulcers. So immediate treatment is to ask the patient to gargle vigorously, try to neutralize and get rid of hypochlorite, which is pollen on the mucosa or on the tongue. Prevention is always better, so start using rubber dam, which is the first standard of care. Now, second incidents can happen. Second category is when you exceed the pressure on the syringe while doing positive pressure irrigation. And when you exceed 30 millimeters of mercury pressure, which is sinusoidal pressure or exceeding the venous pressure, then only your irrigating solution can go in excess with pressure into the periradicular tissues. Now, once this happens, patients start experiencing severe pain. There could be bleeding from the canal. There could be swelling or cellulitis. So this is second category. How to avoid? I already showed you in the video. While doing manual irrigation, never lock the needle. Keep the needle moving up and down. And so the solution flows up and down and the needle is never locked and there is no pressure on the syringe. Also, I told you to use a palm grip, which is more controlled grip. Now, I am also in the process of designing a special syringe for irrigation, which has a thumb ring. So where you have literally control over aspiration and injection, also combined with the new tip, which I showed you. So use a palm grip, don't use the thumb grip. So that way you can prevent the forceful irrigation into the periradicular tissues. And then finally, the third category could be that you inject sodium hypochlorite thinking that it is local anesthetic. That's a disaster that one should avoid. So start using, to prevent that, start using cartridge syringes and use normal syringes for your sodium hypochlorite irrigation. Now, clinically important things. There are 2 points which I want to convey here. That is maxillary sinus considerations. Now, what is that? If you look at the facial vein structure, the anterior facial vein, in most of the times, it communicates at the lateral incisor level. Or when you see a radiograph where there is no bone or the roots are actually into the maxillary sinus, where there is no Schneiderian membrane or where there is no bone. That means the canal is patent to atmospheric pressure or very wide canals like this. In these cases, extrusion is very common and we should actually inspect for this and we should understand the anatomy behind this, and that is why you see this ecchymosis when you exceed the venous pressure. The anterior facial vein or a palpebral vein, when it is since it is interconnected, if you are dealing with the open apex lateral incisor and you forcefully irrigate the hypochlorite, and if you manage to exceed the 30 millimeters of mercury pressure, you can actually go into the anterior facial vein, and that is why you can see ecchymosis at the lower eyelid and the corner of the mouth. You cannot see it here because there is zygomatic um, pad of fat which will not allow any ecchymosis to be shown. So when dealing with lateral incisor, when dealing with molars, always be careful, and if you are in doubt, take a CBCD to see that the maxillary roots are not in direct communication with sinus. Then you are at a danger of pushing your hypochlorite into the maxillary sinus. Now, how do you prevent it? You know beforehand if you take a CBCT. Now, the extrusion of hypochlorite is multifactorial. It will depend on the status of apical foramen, which I just told you, wide canals, open apex cases, use negative pressure. That is the safest because you will not be able to, the solution will not be able to cross the tip of the needle which you are placing for negative pressure. If the canal is patent or not, if the canal is patent, there is a good chance that hypochlorite will travel into the periradicular tissues. If the canal is blocked, then it may not. Then anatomical variations in the venous system, which I just told you about, anterior facial vein. Be careful when irrigating with in lateral incisor and upper molars. And the periapical pressure gradient, which I told you, you should never exceed 30 millimeters of mercury pressure. So it has to be a very controlled pressure on your thumb when you're irrigating with the syringe. Rate of delivery, don't be in a hurry to push the solution or empty the syringe, because 30 gauge side vented parallel needle takes some load on your thumb and palm to empty the syringe. Even if it is 2 ml, it takes a lot of time because the atmospheric pressure, the pressure in the syringe is too high as compared to atmospheric pressure. Location of the irrigation needle, the closer the needle is to the working length, there is potential danger of extruding the hypochlorite. That is why use side vented needles. Size and shape of the canal, I already told you, wide canals, go for negative pressure, don't use positive pressure. Design of the irrigation needle, which I already told you, side vented 30 gauge needle, and I am also working on a different design which will be introduced shortly. Positive pressure or negative pressure, in all other situations where negative pressure is not possible, the canals are too thin or narrow, use positive pressure. Wherever your cannula can go to working length, use negative pressure. That is safest and the most effective way of doing irrigation, because there will be zero extrusion. So maxillary sinus incidents, if it happens, how to prevent? You can use negative pressure. If you happen to push hypochlorite or your irrigating solution into the maxillary sinus, consult an otolaryngologist and they can help. Yeah, otherwise, treatment for hypochlorite extrusion is you have to put the patient on anti-inflammatories, ask the patient to apply ice compressions, warm water saline salt gargles, and if there is swelling or cellulitis, prevent the secondary infection, you may have to use antibiotics and steroids in some of the cases. So I think prevention is always better than what you treat. So using rubber dam, following a strategy whether to use positive pressure or negative pressure, not exceeding the pressure on the syringe while doing irrigation, and choosing right size and design of the needle. Now here is one very clinically oriented tip which I want to give you. How many of you have experienced a lot of pressure while doing irrigation with 30 gauge needle? I am sure everyone must have experienced that. Even I experienced it too. So when you are doing your preparation, use a wide bore needle till middle 1/3. You got it? Use a wide bore needle till middle 1/3. With this, you will be able to convert the irrigation flow from laminar to turbulent, because then there is no danger of pushing your irrigant into the periradicular tissues. As you move ahead and reach apical 1/3, change that needle from wide bore to 30 gauge needle. That will reduce a lot of stress on your hand. And also you will be safe. Also you will be able to clean the root canal system in a better way, because coronal 1/3, pulp chamber, and the middle 1/3, you will be at ease while doing irrigation. Try and do it and let me know the feedback about it. All right, so I think we are done with the presentation, and these are some of the cases which you can see where you can see the lateral anatomy, the bifurcations, the splits, the isthmus, the multiple portals of exit, the C-shaped molars, which are completely filled, the premolars, which are more notorious when it comes to the internal anatomy. Whenever it is distal root for the lower molar, be careful. It almost all the time exits laterally. So with this, I think we will stop here. And if
Sir,
there are any questions,
yes, sir. We got few questions.
yes.
Okay, I will read it. The first one is, what's the average time period of irrigation with activation mechanism?
What is the average time? Is
Period
the
of
question?
irrigation.
See, whoever asks asked this question, the irrigation starts from your access preparation. Okay, it is not that you shape the whole root canal and then start irrigating. It is a simultaneous process. So the time you take from access preparation to your final master apical file, irrigation has to be on intermittently. After every file, you instrument, you irrigate, you activate. Now, if you use sonics or ultrasonics, you will be able to do activation only at the end of the preparation. If you are using pads, you can do it intermittently. But the idea behind, or if I want to precisely answer the question, is access to master apical file, your irrigant should be there in the root canal system. Once the master apical file is complete, then separately activation should be done 1 to 3 minutes, either with sonics, ultrasonics, air sonics, negative pressure, or intracanal heating. Am I clear?
Yes, sir. Sir, next question is, what is the failure rate you see after following this protocol?
Maybe 5%, or less than that.
Okay.
I can't be 100% because then I will be God. So you see, you can encounter failures. It is multifactorial, okay? And
Yes.
nobody is perfect. So to be very honest with you, last about 10 years, my success rate has been hovering around 94 to 96%.
Okay.
And that goes with fresh root canals also and with revised root canals also. But believe me, the day years back I started following and I started talking about irrigation, my life has changed. My clinical practice has changed. And there are so many who follow me. If their feedback is such that we did not know all these years that irrigation was so important.
Okay. So we have another question.
Yes.
If we didn't use EDTA paste with rotary instrument,
Yes.
will it result in heat generation and resistance to instrument?
That is what I showed in my protocol. When you are using rotary instrumentation, your canals should be flooded with sodium hypochlorite. So if you have sodium hypochlorite in the canal and then you rotate your instrument, it will not allow any heat generation. In fact, it will provide lubrication and it will reduce the stress on the file. Now, whoever has asked this question, my question is, why do you need EDTA gel? Initially to establish a glide path, correct? Now, if you have glide path, why do you want to introduce gel again? Think logically. And when you have hypochlorite or twincline in the canal, which is going to reduce the stress on the file and side by side lubricate. Have you ever felt hypochlorite in your fingers? It is soapy solution. So there is nothing more lubricating than hypochlorite in this world.
Okay. The next question is, problems of passing irrigant beyond the apex.
Yes, I just addressed that. Now, it is multifactorial. It depends on the type of canal anatomy you're dealing with. If you're dealing with wide canal, then you have to be very cautious of not applying any pressure. If possible, use negative pressure. Third, use side vented needles. Fourth, don't be angry on the tooth and push the plunger very hard. Be gentle to the tooth, be gentle to the plunger, and don't be into a forceful irrigation. Irrigation has to be passive. It should be 15 ml per minute is the flow rate. So don't be in a hurry to empty the syringe.
Okay.
Now, if you're dealing with open apex cases, then you need to be very cautious. I just talked about if you're dealing with the upper 6 or upper molars, which is in close proximity to the maxillary sinus. So forceful irrigation is a big no-no. Do not lock the needle in the canal. If you lock the needle, then there will be increased pressure on the plunger, and then it becomes a forceful irrigation. So I also addressed about what happens if the solution extrudes into the periradicular tissues.
Okay, sir. So the next question is, are we in any way diluting or reducing the efficacy of sodium chloride by adding etidonic acid?
No, we are not reducing the concentration. Of course, by volume, the concentration may go down, but by action or by its biological action, we are not reducing. In fact, it is advisable to use a lesser concentration of hypochlorite. Now, if you read the literature, hypochlorite can kill everything in 20 seconds from the ranging from 0.1% to 6%. So concentration is not very important. It's the contact time and it's the volume and the refreshment, which is more important. Even 1% hypochlorite is bactericidal. Even 1% hypochlorite can kill all the viruses. And that is why on COVID-19, we're going to use hypochlorite as surface disinfectant. So by adding etidronic acid, you're not reducing the efficacy of hypochlorite at all. In fact, if you use a lesser concentration, it is advisable to use 3%, not 5%, because lesser molecules to react with etidronic acid, and that will have more stability of the solution. So sodium hypochlorite, no dilution.
Okay, sir. How warm should be the hypo solution?
How warm? How to warm?
Yes.
Now, I think I missed on that video, intracanal heating. So once I answer this question, let me see if I can search and show you. Now, there are a couple of ways of warming the hypochlorite. One is, if you do not have any gadget or any device for that, you can very commonly use coffee makers and fill the syringes with hypochlorite. And while you're starting your access preparation, dip those syringes into the coffee maker. So it will just warm it to a 40 to 50 degrees. Now, to add further to it, there has been a lot of controversy on using warm hypochlorite. But if you go and read in the literature, the antibacterial activity and the tissue dissolving properties straight away doubled. Now, why do we call it as warm? Why we don't call it as hot? Warm is something which you can drink, like your tea or coffee. So it should be warm, it should not be hot, if you are directly delivering the solution into the root canal system. So coffee maker is one solution. Second way is intracanal heating, where you are heating the hypochlorite to a temperature of 120 degrees. But then that is to be done in cycles of 3 to 4 seconds, strokes of using any preheated plugger. Now, if you exceed that 6 seconds for 120 degrees, you may irreparably damage the periodontal ligaments. So, most common method of warming the hypochlorite is by using coffee makers. Now, if you want to use intracanal heating, that is also a good method of activating the irrigant or activating the hypochlorite. but there is a way to do it. You have to have a down pack pen with you, and then once the canal is prepared, you pour hypochlorite into the prepared canal and insert the tip into the solution and activate the heat with a rule of 4 seconds and release the switch, allow the tip to cool. Now this is a thermal activation where you allow more free chlorine to be released. In this, you should also understand the boiling point of hypochlorite, which is 95 to 105 degrees. So I would prefer a temperature setting of 100 degrees only for that down pack pen. Now, nowhere it is available. Every down pack pen is available 120 degrees and more. So in coming times, there will be a device specifically designed for intracanal heating.
Okay,
In
sir.
short, there are two methods with which you can warm the hypochlorite. One is extraoral and one is intracanal.
Okay, sir. So one asked about where to get Twin Clean.
Twin Clean is available with Mark Dental or Mark Dental Products Mumbai, and they are manufacturing it. I have licensed my patent to them, and it is available in 100 capsule pack or a 50 capsules pack. And if you want to make 5 ml solution, use 1 capsule. If you want to make 10 ml solution, use 2 capsules. Mark Dental is the company's name or the manufacturer's name, and I don't know if what is his name in Kochi, the dealer. Sabish, what is his name?
Which one, sir? Pads. Mark Randall.
No, in Kochi there is one dealer whom I met.
Medesta.
Medesta. Yes, he will be having Twin Clean.
Okay.
Medesta, correct.
Okay. Sir, which one is the ideal irrigant for pediatric patient?
Pediatric patient, you can resort to using 1% hypochlorite.
Okay.
That is the only time when you dilute hypochlorite.
Okay.
Twin Clean also can be safely used in pediatric patients, but it is better to be reduce the concentration to 1% when using in pediatric cases.
The patient is uncooperative,
then a periodontist will be in a better position to work on it.
okay. Sir, the next question is what about ozonated irrigation?
Ozonated, ozone layer, correct?
Yes, sir. Yes, sir.
Yes, it is a one of the method of disinfection, but it does not have any literature proven about dissolution of pulp tissue. So for disinfection, like you do it with lasers, you can use ozonated water or ozone. There is a device which produces ozone gas, correct? If I am not wrong, I haven't used them, but it is a disinfection unit. It cannot replace hypochlorite because it does not have any tissue dissolution property.
Okay.
It is just an adjunct to whatever you are using. But my point is, if you have something lethal which can kill in 20 seconds by using hypochlorite, why do you need something else?
Yes, sir. We have another one more question. Can you explain once more about positive and negative pressure irrigation?
Okay. So when you are using syringe and needle, it is called as positive pressure. Why? Because the pressure in the syringe is greater than the atmospheric pressure. That is the technical aspect of explaining the positive pressure. In positive pressure, you deliver the solution deep into the root canal and evacuate the solution at the coronal end, correct? You got it?
Yes, sir.
In negative pressure, it is other way around. You suck the irrigant at the apical end and drop the irrigant into the chamber. That's a negative pressure because the pressure inside the cannula which you use is lesser than the atmospheric pressure. So in positive pressure, you push the irrigant. In negative pressure, you pull the irrigant. How do you pull it? You attach the cannula to the suction.
Okay.
Is it clear?
Yes, sir. Yes. Sir, the next question is, can we use air scaler with polymer tips for activation?
You may use it. The question is like you want to use the patch tip with any air scaler.
Yes.
That could be the question, correct? I am
Yes, sir.
assuming. But the patch handpiece is not like any other air scaler. The frequency is changed. The hub is different. Uh, the tip which you get by the manufacturer will not fit onto any other air scaler.
Okay.
And if you compare the devices, the Sonic is costing how much? 38 to 39,000 endo activator, right?
Yes, sir.
Patch is costing 8,500 with 4 tips. So if you do not match the frequency, first of all, the tip will not fit into any other air scaler because the hub is different. Secondly, even if you try to make it fit somehow, if the frequency is not matched, the tip will just break away. Because there has to be a specific frequency to be delivered by air so that it has a frequency and not amplitude. So it is not advisable to use the pad tips on any other air scaler because there were a lot of inquiries to me that can you supply only the tips? We have air scalers. I said I can supply you, but I will not take it back. It doesn't work.
Okay, sir. Sir, is intracanal medicament do anything in cleaning the isthmus area?
Intracanal medicament in a slide which I skipped, I think. After following all this, the protocol which I told you today,
Yes.
if the tooth or the lesion does not respond, or the canals are still weeping, or they are not getting dry, then only use intracanal medicament. If the canals are dry, and even if the lesion is big, you can go ahead with obturation. The lesion will heal. The only indication to use intracanal medicament is when the canals are not getting dry. Then you can use calcium hydroxide, preferably the water-based and not the oil-based. If you decide to place calcium hydroxide, it has to be there at least for 1 week. After 1 week, you recall the patient, remove the calcium hydroxide dressing, see if the canals are dry, tooth is asymptomatic. That is the criteria to go ahead for obturation. When you are completely relying on intracanal medicaments to take care of the tissue in the isthmus, it really does not work because calcium hydroxide does not have the ability and the capacity to digest the tissue, which is which is quite a bit of the tissue. It can digest small tissue tags, but primary action of calcium hydroxide is by way of its alkaline pH, and it is primarily an antibacterial activity. So by leaving behind tissue in the canal and then putting calcium hydroxide will only increase the pain for the patient, if many of you have experienced this. So there is no substitute for cleaning. Don't fall back to calcium hydroxide all the time. I do not use it in my practice unless the canals are weeping. Otherwise, I do not place any intracanal medicament. I just place either a piece of cotton or a Teflon tape and close the tooth. So we should always refrain from introducing the counter irritants to the root canal when it is not needed. So if the canals are not weeping, don't place calcium hydroxide. It will only add up to the problems. Again, repeat. If the canals are not weeping, and if they are weeping, then use calcium hydroxide. That is the only indication which is advisable.
Okay, sir. Sir, next one is when obturating, introduce hydraulics can be done by using obturation pens.
Yes.
Yes.
Yes, because you're compacting the master cone into last 4 to 5 millimeters, correct? Now, I will explain you in a simple situation. Everybody must have seen an ice cream cone, correct?
Yes.
An ice cream cone. You take two cones and you make holes on the first cone. Pour some liquid into, or pour some ice cream into that, and press another cone into that cone. What will happen? Those are the hydraulics. The holes which we have created, the ice cream will start flowing from those holes. So that's an exact situation which you are creating into the obturation. It's a prepared cone and an obturating cone. So when two surfaces slide onto each other, the forces will be transmitted where? Laterally. Correct?
Yes, sir.
That's the creation of hydraulics, because you're downpacking the master cone.
Okay. And the next one is will we use twin clean instead of EDTA
Yes.
simultaneously while doing rotary or after shaping?
See, when you are using twin clean, you don't require anything else. No EDTA, no chlorhexidine, no EDTA gel, no citric acid, nothing you require. Please don't use EDTA if you are using twin clean. Then you are using two chelating agents, which will weaken the tooth structure. So either use EDTA or use twin clean. Don't use together.
Okay, sir. Sir, next one is what's the tip diameter of PATS polymer tips?
It is 25 as the tip diameter. Taper is 3%. Length is 25 millimeters.
Okay. And if we use chlorhexidine, when do we use it? If we use chlorhexidine, when do we use it?
If at all you want to use chlorhexidine, see, normal practices of using chlorhexidine I have seen across the country is that they just try to flush for 5 minutes or keep the chlorhexidine solution in the prepared canal for 10 minutes. Am I right? Or people use as a final flush when doing retreatments. So that is not the proper way of using chlorhexidine. If at all you want to use chlorhexidine, use it as an intracanal medicament. You take chlorhexidine 2%, mix it with calcium hydroxide powder, chair side, make a paste, and then coat the canals with that paste. So chlorhexidine is better used as an intracanal medicament rather than irrigant.
Okay.
Got the point?
Yes, sir. Yes. And
Plus,
will
chlorhexidine is an action of uptake and release of chlorhexidine ions, and that needs minimum 72 hours or more than that. So unless and until you leave chlorhexidine into the prepared canal or in contact with the hard tissues, then only the uptake and release of substantive chlorhexidine ions will happen.
okay. Next one is will sodium chloride extrude periapically while doing rotary in chronic cases?
It may, because if there is a lesion, it's a dead space, correct? And nobody has control over that. So even our sealer also flows sometimes when there is lesion. So ideally, if you are instrumenting with the rotary files, few drops, 1 or 2 drops may just go into the periradicular tissues, but that is not a big problem. That is why most of the times patients do complain of post-operative pain. So post-operative pain is multifactorial. It could be because of passage of some hypochlorite into the periradicular tissues. You never know, or you don't know. So that could happen. But while doing instrumentation, there is no forceful pushing of hypochlorite into the periapex. So
Yes, sir.
it is not a big concern.
Yes, sir. Is 10 ml twin clean sufficient for single sitting RCT?
I told you the irrigation should be in excess of 15 ml. So this is just a guideline to make 10 ml of solution. You should be using 15 ml or plus. This
Okay.
is just to explain you the dilution ratio. Now, if you want to make 15 ml solution, you will have to use 3 capsules. 10 ml is certainly not sufficient as an irrigant.
Okay, sir. And the next question is, what about the use of MTAD?
MTAD, yes, you can use it, but it is again, if you read in the literature, if you want to use MTAD or Q-mix or any other combination, none of them have sodium hypochlorite as their primary component, correct? So you will have to use hypochlorite primarily, and then MTAD or Q-mix will be effective. In fact, Q-mix is a combination of chlorhexidine and EDTA. So when mixed together, they form salts. And MTADA is a good solution, but it is only antibacterial, and it does not have any tissue dissolving property. So if you are trying to say that if I use MTAD and get away by not using hypochlorite, that is not true. You will have to use hypochlorite.
Next one is, how do I know the right pressure on the syringe is below 30 mm Hg?
Now, how much is the pressure you apply when you are using your rotary instrumentation? It is just like the pressure which you put on your pencil, correct? So that the lead of the pencil does not break. Now, while doing irrigation, first important thing is, if you do not engage the needle, you will not exceed the venous pressure. The moment you engage or lock the needle in the canal, you are bound to exceed the pressure. Now, there is no pressure gradient set on the syringe. So the same pressure which you use for your injection of your local anesthetic, gradually, and what you can do is do one exercise, everybody fill a 5 ml of syringe with either hypochlorite or distilled water. Start a stopwatch and put a 30 gauge needle on the syringe and slowly extrude. In a minute, you should be able to extrude 15 ml. That is the amount of pressure you want.
Okay, sir. And
Has
will you
anybody done this exercise before? What is the flow rate? I'm sure nobody must have done it, but do it. Fill 3 syringes of 5 ml, keep it aside, start a stopwatch, and start extruding. 15 ml per minute should be the flow rate.
Okay, sir. Can I ask the next one, sir?
Yes, yes.
Will you repeat how we add and how much we add to prepare twin clean solution with hypochlorite?
How to prepare?
Yes.
Okay. Now I explain it, but all those who want to know how to mix it, that video is on YouTube. You put my name in search box, you will get the video. But again, I will explain. In the packing, there is a cup which is provided in the packing along with the capsules. So that cup has markings 5 ml, 10 ml, 15 ml. So you take that cup, take any hypochlorite, preferably 3%, I would suggest, and hypochlorite till the 10 ml mark. Take 2 capsules, break open the capsules, and dispense the powder into the 10 ml hypochlorite. Stir it for half a minute. Wait another 30 seconds, and then ask your assistant to load the syringe. Clear?
Okay, sir. Yes, sir. And in non-vital tooth with pus oozing, what is the procedure for irrigation and what kind of dressing is given?
if you open the tooth and if you see the frank pus draining out, when you see the frank pus draining out, don't start with hypochlorite straight away. Start flushing it with normal saline. Now, whenever there is pus draining, that means there is a lot of pressure or hydrostatic pressure in the periradicular tissues. Now, the pus will stop draining after, say, a minute or so, depending on the size of the swelling if the patient has. And rest of it will be inflammatory exudate. So do not start using quinacridine or hypochlorite in pus draining situations. Clean it with normal saline first and wait till the pus is completely out. And then only start using the sodium hypochlorite alternatively with EDTA or quinacridine. That should be the approach towards it. In terms of dressings, given a situation where I encounter this situation, I will complete my shaping and cleaning in the same visit and see if the canals are dry. If they are not dry, which in most of the cases they will not be, I place calcium hydroxide and give a closed dressing. Now, there will again be a question that what about open dressings? See, we are clinicians. Literature says that never keep the tooth open. Keep it always closed. But as a clinician, and I must share you, today I completed my 25 years of clinical practice. So Akshay Tritiya was the day when I started my practice 25 years ago. So in these 25 years, there have been situations where the moment I close the tooth, patient used to come back with swelling again. And that happens with every clinician. So in such situations, you don't let the patient go out. You keep the tooth open and ask him to wait in your maybe reception area, maybe for half an hour or 1 hour. And that will allow the inflammatory exudate to completely clear off. And then you can close the tooth. If the canals are dry, I will not prefer putting any intracanal medicament. If the canals are weeping, I will place calcium hydroxide and close the tooth.
And so one asked about best intracanal medicament.
Calcium
On
hydroxide is intracanal.
On weeping canals also.
Calcium hydroxide is the best intracanal medicament, and further to it, maybe triple antibiotic paste. Locally acting antibiotics have got no role, like single antibiotic like tetracycline. Yes, triple antibiotic paste in some cases where you want to have maybe regeneration or apexogenesis. These are some of the situations where you may have to use triple antibiotic paste. Frankly speaking, I have never used it. I've been using calcium hydroxide whenever it is necessary. Otherwise, I don't use calcium hydroxide, or nor it is recommended.
Will you use lendulospiral for application of root canal sealer?
Never. Don't use it. Don't use anything for application of sealer. Use your master cone to carry your sealer.
Is flow of root canal sealer is also important for filling lateral canals and apical data?
Of course, but provided they are clean, provided they are devoid of the accumulated hard tissue debris. If they are completely loaded with accumulated hard tissue debris and you use best of the sealer which has best of the flow, it will not flow. So definitely the sealer consistency, the flow definitely plays important role when it comes to entering into lateral canals. As a clinical experience, epoxy resin based sealers, AH plus has got fantastic flow properties to flow into the lateral canals and the apical delta. When you are using bioactive sealers, bioceramic sealers, filling of lateral canals and apical delta may not be so important because it is an environmental seal and not the hermetic seal, because it's a sustained activity or antibacterial activity wherein the bioactive sealers will try to have a hydroxyapatite layer. So it really does not matter. That is why with bioactive sealers, you tend to have a single cone obturations. But yes, flow property is one of the important aspect of the sealer when choosing it.
Next one is the indication of usage of calcium hydroxide and iodoform combination.
Iodoform, I will not recommend because it is thought to be potent cytotoxic. If you want to use calcium hydroxide, use plain water-based calcium hydroxide. I will not. I have never used iodoform. Maybe in pediatric cases it may be helpful, but in adult endodontics, it is better to use only calcium hydroxide. At the most, you can combine chlorhexidine.
Can you please explain manual activation using GP again?
Manual dynamic agitation.
Yes.
Manual dynamic agitation, no?
Yes.
Okay, now you have finished your preparation. For example, 2506. You have selected the master cone. Your working length is 19 millimeters. You cut that master cone 2 millimeters short. Pour the prepared canal with sodium hypochlorite. Completely flood the canal with sodium hypochlorite. And you have already cut 2 millimeters short of your working length. And take that master cone, hold it in the tweezer, place it into the canal, and this should be the short amplitude strokes, about 100 strokes in a minute. That is how manual dynamic agitation is done.
Okay, sir. So with that, we finish our question and answer section.
We finished question answers. Okay.
Yes, sir.
Yeah, good evening, sir. And all. I'm Sanal, IDA Ernad branch secretary.
Oh, you are in the car?
Yeah, of course. There is no current because of some.
I was observing you. I said, which kind of window is this? So, then I saw the seat belt.
Okay, that was a great section. And the International Association Ernad branch conducted its 6th webinar on this topic: events activated irrigation complication and its management in endodontics. It was a great successful program with a great mentor, Dr. Mandar Primkar.
My
First
pleasure.
of all the participants, those who are made this program a great success, especially Idea Ernad, Idea Malabar branch for the technical support, and from the bottom of my heart, on behalf of Ernad branch, I appreciate and thankful to Dr. Mandar for being our faculty, sir, and you have spent more than 2.5 hours. I think
I can
3 hours.
spend 1 minute now.
Your valuable time for us, and special thanks to Dr. Sabbish.
Yes. Sabbish, and I don't know if Dr. Tom is there online.
Okay, Dr. Tom, sir.
Good evening, sir. Can you hear me?
For us 4 days back. Anyway, thanks.
Hello, sir.
Oh, same.
So, hearty congrats for completing 25 years in practice. And nice to see you again after one month, sir. I've been watching from starting of your webinar. It was fantastic. Fantastic thing to attend. Excellent presentation, sir.
Thank you. Nice to see you.
Thank you, sir. Nice to see you, sir. Thank you, Ernad branch, for this wonderful opportunity. Those who missed this webinar, they have missed it.
Okay, thank you.
Thank you.
Okay.
Okay. Stay home, stay safe. Bye-bye.
Bye.
Okay, thank you.
Okay, thank you.
Sir, are you sir there?
I can leave the meeting, no?
Yeah, sir. Thank you very much, sir.
Yeah, welcome.
It was a treat for our knowledge. Thank you so much.
Take care. Stay home.
Okay.
Thank you, sir. Stay home. Take care.